Good evening. Good evening to all. I welcome you all for the Bodhana series of TNFOG. This Bodhana is done last Saturday of every month. I invite our President Dr. Revati Janaki Raman Madam to tell few words about this Bodhana.
Good evening all. In the Bodhana we are having a lot of discussions with benefiting the postgraduates, and this time we have got an important topic, RH negative. Now, even though we know a lot about RH negative, still the problems are there for the babies. So, in which situation, how to manage is very, very important for the PGs to know about. And I am sure this discussion is going to help a lot for all the viewers, not only PGs, but also practitioners. So I welcome you all once again. Over to Kalpana.
Ma'am, Kalpana ma'am, join panel. Sambat ma'am or Kalpana ma'am, join panel. You can start, ma'am. Sambat ma'am.
Kalpana, no problem. I will introduce her. Today, the PGs from Apollo Hospital, sir. Dependent PGs are going to present the case on RH negative. And the internals being Dr. Sumanna Manohar from Apollo Hospital, consultant OBGN with subspecialty interest in fertility medicine, endoscopy, robotic surgery, and high-risk pregnancies. In fact, invited faculty in many national conferences, contributed few chapters to OBGN books, and fellow representative of South Zone AICC RCOG and Part 3 MRCOG examiner. Welcome, madam. Sahiti, then you can put Sunita Samal. Dr. Sunita Samal is the second examiner, and and UG and PG teacher for the past 16 years. Special interest in laparoscopy, hysteroscopic, and vaginal surgeries. She has 50 publications into her credits and award Best Poster Award in AICOG 2015 and 2017, and Dr. Anjalakshi Chandrasekhar Award for Best Research Paper in Oxy and International Scientist Award on Science and Medicine in 2021. She has organized many CMEs and presented papers and members of many organizations. Now this month we have the external examiners from Dr. Saxena from New Delhi. 1 minute, I'm not. She is a WHO fellowship in gynec oncology from IARC Lyon and the principal investigators in ICMR projects. And she has an experience of 28 years and organized. She is the past treasurer of NARCHI 20 to 21 and EC member of AOGD Fetal Medicine Committee, Endometriosis Committee, and reviewer of AJOG, JOHI, and JCATR. Many publications to her credits, and she is an invited faculty for many national and international conferences. Welcome, Dr. Upma Saxena.
Thank you, madam.
Our own Dr. Shanti Gunasingh. She is the retired IOG director and consultant in Mangalam Hospital, past president of Oxy, and former HOD of Kilpak Medical College. And she has served as a project director for many government programs and past president of WDA, vice president of Chennai Menopause Society, and master trainer for many government programs, recipient of Dr. A.L. Mudaliar Traveling Fellowship, and invited speaker in national and state level conferences. And she is our active past president of Chennai Society. Welcome, Shanti Madam.
Thank you so
much. The presenters are Dr. Shanas Nasin and another one, Huma?
Vinodini.
Dr. Vinodini from Apollo Hospital, Chennai. Welcome, PGs. Now you can present your case. Dr. Sunita, avangala present பண்ண சொல்லுங்க.
Yeah, Senaj. Yeah. Make it full screen.
Good evening, ma'am. Yeah. We are not able to see the slides. Yes, ma'am.
Yes. You can see the slide now. Yeah.
Ma'am, I start presenting, ma'am.
Yeah.
Please go ahead.
Good evening, one and all. My name is Dr. Shanas. I'm DNB PG in Apollo Hospitals. Today we'll present a case on RH allo immunization. So our patient, Mrs. Z, is a 28-year-old homemaker who comes from Mandaveli, belonging to the upper middle socio-economic class. She has an obstetric score of G3A2 at 9 months of gestation, with blood group B negative and husband blood group O positive. Her LMP is on 10 August 2022.
Weeks of gestation, not months of gestation as such initially. Okay.
Yes, she's 37 weeks and 2 days, ma'am.
Okay, please continue.
Her EDD is on 17th of May 2023. She's come for her routine antenatal visit. History of presenting complaints. She's able to feel her baby's movements well. No complaints of pain abdomen, no complaints of vaginal bleeding or draining, no complaints of AC fatigability or breathlessness, no complaints of swelling of the feet, headache, epigastric pain, vomiting, or any history of reduced urine output. No complaints of dysuria, no complaints of bowel disturbances. On elaborating her present pregnancy history, the first trimester, she had a spontaneous conception, which was confirmed by urine pregnancy test at 40 days of amenorrhea. Her blood grouping and typing was done in her first antenatal visit and was found to be B negative. An ICT was done on the same visit, which was found to be negative. There was no history of pain abdomen, vaginal spotting or bleeding, no history of excessive vomiting, no history of fever.
I have a query here. It was necessary to get the IC done before getting the husband blood group done? Because she was B negative.
Yes, ma'am.
You should have mentioned here only that husband was positive. That's why you got a IC done.
Yes,
ICT done because it gives a wrong message. Because
Yes.
RH negative is only when mother is RH negative and husband is RH positive.
Yes,
If both are negative, you don't have to do anything. No need for getting a ICT done. Okay, proceed.
So on finding that she was RH negative, her husband blood group was done, which was found to be B positive, and the ICT was done in her first trimester, which was found to be negative. There was no history of fever with rash, no history of any invasive procedures in the first trimester, no history of radiation exposure or unknown drug intake. She took her folic acid supplements regularly. A dating scan was done and was told to be normal. An NT scan was done, which was also told to be normal. The first trimester blood screening was also done, which was found to be low risk. The second trimester history, she had her quickening at 5 months of gestation. Her iron and folic acid supplements were taken regularly. An anomaly scan was done and was told to be normal at around 20 weeks. Injection Tdap was given. Oral glucose tolerance test was done and was found to be normal. Her ICT, which was repeated at 28 weeks, was found to be positive with a titer of 1:32. We had an ultrasound for the MCA. For the MCA PSV Doppler, and that value was around 1 mean of median. She was advised to come for a follow-up ultrasound after 2 weeks.
By what method was antibody titer done, ma? Is it relevant?
Ma'am?
Which method ICT was done? Whether it was a tube method or gel method? That's what Dr. Shanti is asking. You have not mentioned how it was done, ICT. You just said antibody titer was 1:32 because it's different for both the types of test. So you should know.
Yes, ma'am.
So you're not aware which method, hai na?
What are the methods by which it is being done?
She's not aware.
Tube and gel, ma'am. But for our patient.
For your patient, what was done?
It's important because the critical titer is different for both the methods.
Yes, ma'am.
Can you tell theoretically what are the titers for tube method and the gel method?
What is critical titer, ma?
Ma'am, it is the dilution levels, ma'am. It is the level at.
Yeah, dilutions are, it is being done in dilutions.
But what is the clinical implication?
Yeah.
Zainaj, you have to tell what is the meaning of the critical titer. Why you are telling that value is critical?
Because the levels of antibody in the maternal serum are significant to cause hemolysis, ma'am.
To cause fetal anemia.
Fetal anemia, yes.
Fetal anemia is the correct word. So for critical level, for tube method is 1:16, and for the gel method is 1:64. So if you take it by tube method, then it is high. It is above the critical level. But if you take gel method, then it is normal. Okay,
Yes.
that's the reason you should tell which method is done. Usually we are doing tube method.
Yeah, it was done tube
Tube
method.
method.
The majority of time is being done by tube method because gel is costly.
Ma.
Okay, proceed. And one thing I just want to add, in TDAP, you should specify which week it is given because this is usually given after 27.
28, yeah, 20,
And you have
20
included it in second trimester. Huh? So it's giving the little wrong message. TDAP, TT you can give at this point, but TDAP should be always given just after 27. So
Yes.
usually in the third trimester you give.
I think, Sena, you have wrongly mentioned the TDAP vaccine in the second trimester.
It should have
Yes.
been TT because we give 2 doses, one TT and other TDAP.
What
Yes.
doc-
So you have to read that also. Huh? Go ahead.
Yes, ma'am. This was done at TDAP was given around 28 weeks, ma'am. Sorry that I put it in the second trimester history. Third trimester history, she was able to perceive fetal movements in all her visits. She had her follow-up ultrasound with MCA Doppler at 30 weeks, 33 weeks, and 35 weeks, and the values were as follows. Up to 33 weeks, it was only one of median. At 35 plus 1 weeks, it was less than 1.29. She was given 2 doses of steroids at 33 weeks.
So
Growth
can you
scan-
tell? What can you tell? This is normal or abnormal?
She had a normal MCA Doppler now.
So what is the cutoff for abnormal?
More than
1.5.
1.5.
Why do you take as a cutoff of 1.5 multiple of median as abnormal? Why? There's a reason for it. Why? Because if it's more than 1.5, then there is a risk of moderate to severe anemia, fetal anemia. Okay.
Yes, ma'am.
This is that shows that the baby doesn't have anemia, which is less than 1.5. Okay.
She was given 2 doses of steroids at 33 weeks. Growth scans at 35 weeks and 30 weeks and 35 weeks were totally normal.
This is
There was
also
no-
wrong. Why have you given steroid? There's no need for giving steroid.
Yeah.
Because steroid should be given if you're planning to deliver her, not just empirical, because it increases the risk of neurodevelopmental delay in the baby.
So, Sena, she
At
had
this
any
point- at
preterm
this
labor
point, but-
symptoms?
It's not indicated in this case.
No, I don't routinely know. Sena, she had any problem like any threatened preterm, anything? Because routinely we don't give steroid, no? Like without anything.
Yes, ma'am.
So she had any threatened preterm, anything?
Her
Why
Okay.
not given, Ma?
So when you write, you should specify why you have given it. Okay. You can't just keep blanketly, you can't give steroid cover to all the patients. It is a double-edged sword. Huh?
yes, ma'am.
Okay. Continue.
There was no history of pain, abdomen, vaginal bleeding or draining. There was no history suggestive of raised blood pressure. There was no history of dysuria or bowel disturbances. Iron and folic acid tablets were taken regularly. Her past obstetric history, in 2019, she had an MTP done for missed miscarriage at 10 weeks. DNC was not done and anti-D was not given. In 2021, she had a spontaneous miscarriage at 16 weeks.
Sana,
Yes, ma'am.
what do you mean?
Ma'am?
MTP means what do you mean?
Ma'am, she was given medications for the missed miscarriage, ma'am. If you
So
prescribe-
it is not MTP. MTP is when you do it for a unwanted pregnancy. It is a wanted pregnancy. It was missed. So MTP terminology is wrong.
So,
Sorry, ma'am.
and STOP. That is the standard thing. Okay. By medicines. Okay, ma. Please continue.
She had a spontaneous miscarriage at 16 weeks at her home. DNC was not done.
Where was this done, ma? Medical management?
Ma'am, elsewhere, ma'am, not in our hospital.
No, whatever it is, you should tell. I'm not telling your hospital, amma. But
Yes,
you should tell, no, Shanas, where all that. And you said anti-D was not given. do you have to give anti-D for this?
No, ma'am.
You're very categoric about that? What do guidelines tell us, ma'am?
What are the indications for giving anti-D? During
Ma'am,
pregnancy.
any risk of any event leading to risk of fetal-maternal hemorrhage, anti-D has to be given, ma'am.
Enumerate. When will you give antenatally anti-D?
Ma'am, according we divided as first trimester, second trimester, and third trimester, ma'am. First trimester, any surgical management used for termination of pregnancy, ectopic pregnancy, molar pregnancy, threatened abortion more than 10 weeks, any abdominal trauma.
What about if less than 10 weeks you will not give?
Ma'am, if surgical management is not done.
No, you have to give. You have to give. Dose is different, but in India we have a single dose, but you have to give.
Yeah, but WHO says
In
less
med-
than, so you should know at least the guidelines and what you do. We always think better to give for RH negative. But-
We say when in doubt, give.
Yeah,
When in
But
doubt,
WHO clearly states that less than 12 weeks, they say unless they have profuse bleeding, no need to give. But then you should always remember in RH negative, when in doubt, kindly give, because that is much easier to manage later. But you should be clear about your guidelines, ma. WHO clearly states that, so that you should be aware. When
Yes.
is what do you mean by RH negative, ma? For this
Ma'am,
patient,
the mother doesn't have a particular antigen, which is
what antigen?
which
the D
antigen?
antigen, the D antigen, ma'am.
Capital D.
Yes, ma'am.
Capital D. What are the other antigen which besides D, which can cause sensitization? RH
The
sensitization?
capital C, ma'am. Kel antigen.
No, Kel doesn't come here, ma. Kel kills, that is different.
Kel is not RH. No.
No, what madam is asking is RH.
RH.
T and E, ma'am.
Pardon?
T and E, ma'am. Capital C,
Small c, D, E,
E, ma'am.
Okay, what about G, ma? Do you know about G now?
Yes, ma'am.
What do you know about that?
There is a possibility of having hemolysis, ma'am, with G.
Not hemolysis even. So many times it will be positive, okay? But then fetal effects are not that high. That you should know. So
So-
lot of things nowadays, okay? You should know about all these things. We should have transfusion medical specialists, hematologists. So Ujisian managing alone, everything is gone, okay?
So I just want to add here that Kel also is different from RH, but it also increases the risk of fetal anemia, and it can cause even missed abortion less than 12 weeks. And the
Yeah.
critical titer for Kel is less. It is
Less.
1.4. So it is so dangerous, Kel. So these are the two common one, RH and the Kel.
Yes.
Yeah, Santi ma'am, can I intervene 2 minutes? Just
Yeah.
1 minute. Ma'am, this less than 10 weeks, actually this recent FIGO 2022 guideline, they have mentioned if it is a medical abortion or it is a spontaneous abortion less than 10 weeks, because the chance of isoimmunization is very less, around 0.1 to 0.4%. So you need not have to give. If it is ectopic or it is a surgical evacuation, then you have to give the anti-D.
What I'm saying, Sunita, that is the recommendation is do
Yes.
not.
Yes, madam. Yeah.
WHO clearly says that less,
Yes.
not even 10, less than 12 weeks. That is what they say.
Hmm.
Then what I'm just saying is, although guidelines state that when in doubt, always give.
Yeah, that is true.
No,
When in doubt, we'll
yeah.
definitely give.
In
Yeah.
India, sometimes patients are not very sure about their period of gestation. So when in doubt, it's better to give than not to give.
So
Yeah.
do you think instead of saying 12 weeks, just say less than 20 weeks and more than 20 weeks? That's what the FOXI guidelines says, the recent FOXI guidelines.
20.
Less than 20 weeks, give 150, more than 20 weeks, give 300.
Actually, we have single dose in India, so that point
Yeah.
doesn't come here. We have just 300 microgram.
Yeah, you can always discard the other half.
No.
That's what I do actually in clinical.
Acha, you discard. Acha, we are giving full dose for everything.
Yeah.
We are giving 300 only. Because too costly. If I ask patient, either you give, if you have 2 patients, you can divide. Throwing away, it's little tricky.
Okay, ma, please continue. But where's your presentation?
Yeah, it can.
Can see.
Please continue, ma.
Yes, ma'am. In 2021, she had a spontaneous miscarriage at home at 16 weeks. DNC was not done and details of the management were unavailable. There was no history of any ITD being given for that pregnancy also, ma'am. No history of any blood transfusion during both the pregnancies. Her marriage.
See, where was this second, did she have, you should clearly tell ma, that is where she had her ANC and being our incompatible couple, okay, they would have done an ICT. So all that you have to mention, you have to ask for the history.
Yes, ma'am.
Whether in the, when do you first do ICT for an RH incompatible a woman with RH negativity whose husband is positive?
The first antenatal visit, ma'am.
Yeah. Then 16 weeks, what happened? Did she have ANC? All that you should tell her, ma.
Okay, ma'am.
What was her ICT like that time? And expelled at home also, usually they attend somewhere after that, isn't it?
Yes, ma'am.
No, where she had the checkup, the second pregnancy? She's a local patient or patient from outside?
Local patient only, ma'am.
Okay.
Because it's very unlikely in scenario. Like when we years, of course, yes, but not nowadays. Let's be aware of all these things. Okay, please continue, Amma.
Continue.
Her marital history, she is married for 5 years, non-consanguineous marriage. She is married to Mr. S, 30 years old, whose blood group is O positive. There is no history of any contraceptive use. Menstrual history, she had regular cycles, moderate flow, no pain. Her LMP was 10th of August, 2022.
I just want to add in this obstetric history, no need for writing MINAC. This is unnecessary. It should be in gynae history, not in OBS. It's an OBS case.
Yes, ma'am.
Okay.
Past history, no history of diabetes, hypertension, thyroid, bronchial asthma, tuberculosis, or epilepsy. There was no history of blood transfusion in the past, no history of any abdominal trauma. Ma'am, sorry, ma'am, this history was wrong, ma'am. I added it by mistake.
So there's a history of ectopic instead
no,
of. Achha, this is wrong.
Her family history, no significant history of comorbidities in the family. Her personal history, she takes mixed diet, normal sleep pattern, normal bowel and bladder habits. Treatment history, she's taking iron and calcium supplements. Her examination findings, general examination, anthropometry, she is moderately built and nourished. Her height is 155 centimeters. Pre-pregnancy weight was 58 kilos. Her present weight is 69 kilos. Her weight gain was 11 kilograms in the 9 months. Her pre-pregnancy BMI is 24.16. There's no paler fetal edema.
Positive finding only. What are any positive finding in her general physical?
Nothing, ma'am.
Okay, then come to abdomen.
Abdominal examination. After getting a verbal consent and ensuring her bladder is empty, she was examined in supine position and exposed from Zipfi sternum to pubic symphysis. On inspection, the uterus was longitudinally enlarged, devian nigra and stria gravelorum present. Umbilicus flushed with skin surface. All quadrants moved equally with respiration. No visible sinuses, dilated veins. Her hernial orifices were free. Her fundal height corresponded to 37 weeks. Fundal grip, soft, broad, non-ballotable mass suggestive of breech was felt. First pelvic grip, hard, round, relatively ballotable head was palpated, suggestive of cephalic presentation. The second pelvic grip confirmed the finding of the first pelvic grip, and the head was 4/5 palpable, just fixed. Umbilical grip, uniform resistance was felt on the left side, suggestive of spine, and irregular smooth nodules were found on the right side, suggestive of limb buds. Auscultation.
What is this umbilical grip? I've never heard of it. Lateral grip hota hai.
Lateral grip.
There's no umbilical grip.
Okay, ma'am.
It's a lateral grip. So you write fundal grip, lateral grip, then pelvic grips.
First pelvic, yes.
There's nothing entity known as umbilical grip.
Sorry.
Okay, continue.
Her fetal heart sounds were good and heard in the left spino-umbilical line. Summary.
Continue.
She's a 28-year-old Mrs. Z with 37 weeks of gestation with an obstetric score of G3A2 and blood group of O negative. She's married to a RH positive husband. She's had 2 abortions in the past. Ma'am, this is a little wrong, ma'am. I'm really sorry.
I think here in summary, you will directly say it is a RH immunized pregnancy with, okay, first RH immunized pregnancy rather than
Okay,
iso-immunized, you can say, there is no need for repeating what you have already told.
okay, ma'am.
The diagnosis you have come as iso-immunized, you have written here. Okay.
What else is there, ma, here? See, just because it is an RH negative class, this is also what isn't she a case of BOH?
Yes, ma'am.
Huh?
2 abortions in the past.
2 abortions.
2 abortions, is it BOH or not?
3.
Tell me.
What do you understand by bad obstetric history? What is your understanding? Madam is saying, Dr. Shanti, bad obstetrics. So what do you understand by it, bad obstetric history?
She doesn't have a live child, ma'am.
No, that is not bad obstetric history. If the outcome of the previous pregnancy can affect the outcome of this, because she had she has 2 previous abortions, so she could have, but now she's term. So, you know.
Whatever it is, Sama, see, you should have investigated. See, just because she is RH negative, you just can't tell about only RH negative investigation. This is a case of BOH2. So we should have done all, you should have told me about that she was investigated for this, she was investigated for that. All that you should have an open mind. She can have 2 problems also at the same time. We should not miss such things. You follow me, Shanas?
Yes, ma'am. Yes, ma'am.
So what
You can mention whatever investigation she has done, you can mention here now. I think you know that.
See, just because it is an RH negative class, you should not tell only about that. What, Shanas?
Shanas, you can tell about the investigation, baby. What are the investigations done in this case? I think she has told.
Yes, ma'am. In the first trimester, all routine blood investigations, ma'am.
What do you mean by routine?
Tell all the blood tests, Ainash. Whatever investigation has been done, you mention all the tests.
Her complete blood count, ma'am. RH grouping and typing, her viral serum viral markers, her urine routine analysis, her thyroid levels.
What else, Sama?
Shahnaz, what about OGTT? We are so much emphasizing about that. Oral glucose tolerance test.
She has no second trimester, ma'am. I mentioned.
You have to do OGCT, isn't it?
Yes, ma'am.
Was it done?
Yeah, you mentioned Shahnaz, it was done. You tell
yes.
that. You mentioned
yes,
already. It was done.
It was that, ma'am. And was found to be normal.
Yeah. ICT has been done. Okay, you didn't do for, you were very confident, you never did that investigator for APLA. Because after heartbeat, I mean, after the heartbeat has disappeared, after it has appeared, no? It is nearly 10 weeks. So, what is the criteria for investigating for APLA? What is APLA, Amma?
Antiphospholipid antibody syndrome, ma'am.
This case fit into that probably.
I think, madam, APLA test for done for her because of RS negative. She didn't like.
No, I think
yeah, they're supposed to tell. Yes, madam.
Okay.
Shine, can you tell me why MCA PSV was done in this case when her levels were above critical level? Keto were critical. Why MCA? Why we do MCA PSV?
To detect if there's any severe, I mean, any degree of fetal.
Why? There are so many vessels in the body, why we all do only middle cerebral artery?
Ma'am,
peaks
when
for
the
long?
baby is anemic, ma'am, there is an increased cardiac output and the resistance to the vascular resistance to the brain reduces and blood flow to the brain increases, ma'am,
Hmm.
as a part of sparing.
So where you should do, how to do MCA PSV? Any idea?
Ma'am, we see the origin of the MCA from the internal carotid, ma'am.
Hmm. And which part of MC you take? You insunate to calculate MCA PSV? Which part? You have to take it immediately within the 2 mm, just where it arises, because it decreases the false positive. What we want is, we don't want to label it falsely that the baby has fetal anemia. So what is the sensitivity, specificity of MCA PSV? We are now routinely doing for all our patients, where it is in this case you did it because it was above critical level. Okay.
Yes.
So
Yes,
why? What is the sensitivity, specificity, positive predictive value, negative predictive value, MCA PSV?
Ma'am, 100% specific, ma'am. And
it's not specific.
Sorry, ma'am, 100%
sensitive.
sensitive. 100%
Sensitivity
sensitive.
and 100% negative predictive value. Okay.
Yes, ma'am.
They could be false positive in 15%.
12%. Yes,
So 12 to 15%, it could be false positive, but if you see the trend, you will be able to overcome that false positive.
Yes, ma'am.
Okay. So we have only one case.
There's another case, ma'am.
Manage, Amma.
Where is Binodini?
Yeah, I'm here, ma'am. Can I share my screen, ma'am?
Amma, no, we have not finished this one
Okay.
yet.
Okay.
You have to manage this, isn't it? Huh?
So Shaheen, if this level would have been below critical level, then what you would have done? If this, in this case,
I would have given anti-D, ma'am.
If below critical level, if negative, then you have.
Sorry, if negative anti-D, ma'am.
So can
If
you
below
describe-
critical level, we keep monitoring the values, ma'am. Every 4 weekly.
No, then you tell me, how will you manage your mother who is RH negative? So she is negative, husband is positive. How will you manage if she continues to be ICT negative? Can you tell me from the very beginning? So you will do it first.
ICT at the first visit.
ICT, yeah. Then
At the first visit, and if it's going to be negative, then I do one test at 28 weeks, ma'am.
why do you want to do at 28 weeks? You're right. Why you want to do at 28 weeks?
Because the risk of a fetal-maternal hemorrhage increases as the gestational age increases, ma'am.
No, that is not the reason.
Uh,
What is RADAP? Heard of this? RADAP? What is routine antenatal anti-D prophylaxis? What is it?
One dose of anti-D, 300 micrograms given at 28 weeks of gestation.
So you want to do it because you want to give routine antenatal prophylaxis. So you will give it only if she is ICT negative. That's why you are doing it. Because
Yes.
during pregnancy, the risk of sensitization is very less, 0.1%. If it's a healthy pregnancy, there is no abruption, placenta previa, no IUD, then the risk is very less. And then how will you, once you have given at 28 to 32 weeks, then what will you do? Can you elaborate? Will you continue doing ICT once you have given
No, ma'am.
prophylaxis?
Why?
Why?
It will be positive, ma'am, within the first 4 weeks.
How much positive?
Positive?
Ma'am,
How
How
long
much positive?
positive? How do you identify it?
it will be around 1:4 dilution, ma'am.
So it is a common mistake. In outskirts of India, the people get this ICT then even after the routine prophylaxis, and it comes positive, and the patient is there. So you don't have to repeat it. And you want to deliver her till which period of gestation? Before which period of gestation? If you have given anti-D at 28 weeks, then when will you induce her if she continues the pregnancy?
40 weeks, ma'am.
Why you want to induce at 40 weeks? Why you don't want to allow her to go beyond 40 weeks? Any reason? Any reason for that? Because the effect of anti-D remains till 40 weeks.
Yes.
It remains till 12 weeks. So you have
12
given
weeks.
28, so it will last till 12 weeks. What is the
Yes.
half-life of anti-D? Any idea?
23, 24 days, ma'am.
Huh?
It's
23 to 24 days, ma'am.
yeah.
So in case the patient is bleeding, okay, and she's ICT negative, she's placenta previa. So how will you manage that case? Patient is ICT negative, and you have given anti-D, and she bleeds, keeps on bleeding. Then what will you do?
We have to calculate the amount of fetal-maternal hemorrhage, ma'am.
Why you want to go? You have already given the routine prophylaxis. So how will you manage this case? No, it's already given. You will at 3 weeks. You will keep on repeating the ICT. If it's ICT negative, you can keep on repeating giving the prophylaxis. Okay.
And you don't give it before 3 weeks. That is what madam is
Yes. Yes,
looking
ma'am.
for. Okay.
Yes, ma'am.
In case the patient and when that patient delivers, this patient husband she delivers, then what will you do? What test?
We give a postnatal prophylaxis of anti-D.
No, won't you do
Blanket to all.
won't you do a grouping typing for the baby?
We have to collect the cord blood, ma'am.
So it's very important for all Rh negative mothers. You have to get a cord blood done. So you write big bold letters, cord blood to be taken in all Rh negative mothers. So what all do you send cord blood for?
We collect about 5 ml of blood, ma'am, and send it for Rh grouping typing, DCT, hemoglobin, hematocrit, and bilirubin levels, ma'am.
So if it comes DCT negative and baby is also negative, then you will give anti-D.
No need for postnatal.
You said you will give it to everyone. So if only if the baby is DCT negative and Rh positive, then only you will give. Otherwise, no need for giving anti-D.
Yes.
And within how much time you have to give anti-D to prevent for
72 hours.
If you miss that date, then so
given up to 28 days, ma'am.
You can give up to 28 days. So this giving all these things, how much is if you don't give, how much is the risk to the mother to be sensitized?
16%, ma'am.
And by giving this, you're reducing it by
1.5.
You
reduce
it
by almost 90%.
Okay. By 1 to 2%. But you have given, given one anti-D at 28 weeks too. So in that event,
0.5% will be there.
0.2, ma'am.
Yeah, 0.1%. So that is the importance of anti-D. So what dose do you give, Amma?
The routine antenatal anti-D is 300 micrograms, ma'am.
Okay.
So intramuscular.
Shaheen, how many IU? 300 microgram is in international unit, how much? So it is 1500 that you should know. Huh? 1500 international unit or 300 microgram. Okay. And how much it will neutralize?
Ma'am, not able
how
to.
Much fetal blood it will neutralize?
The standard 300 micrograms will neutralize around 30 ml of whole blood, ma'am, fetal whole blood, or 12 to 15 fetal RBCs, ma'am. 15 ml of fetal RBCs.
So in which condition you will look for fetal-maternal hemorrhage? In which cases there is excessive fetal-maternal hemorrhage? In which condition?
In any antepartum hemorrhage, ma'am, like abruption, placenta previa, external cephalic version.
Okay.
Any invasive procedures like chordocentesis, amniocentesis.
All these procedures we usually 300 microgram is good enough. So usually in abruption and fetal death, or you have done ECV, then you will look for, otherwise nahi. How do you look for fetal-maternal hemorrhage?
The Kleehauser-Betke's test, ma'am.
Only Kleehauser-Betke, which is the best test.
Flow cytometry also.
So it's not available most of the time. So we do flow. What is the principle of Kleehauser-Betke's test?
Ma'am, it's an acid elution test. Where the adult hemoglobin is prone for acid elution. However, the fetal hemoglobin is resistant to it. So on diluting it with an acid buffer, all the maternal blood cells will look like ghost cells, and only the fetal blood cells will be visible. So the percentage of the fetal blood cells is taken, ma'am, per 1000 adult cells, and is multiplied by 15.
So in which condition, in which maternal condition you can't do Kleehauser-Betke test? Where, in which condition the maternal blood will not be eluted by acid? In which Mother is thalassaemic. Mother is
Thalassaemic.
thalassaemic. Then they will not get eluted. Okay, so this is not feasible in those cases.
Talk
Dr. Shanti, you want to ask?
for a mental test and then only flow cytometry. Because flow cytometry is costlier. It is not freely available.
And we can do a screening test, which is a Rosette test.
Yes,
Okay, that is a screening test. It's not a quantitative test. It is a
Yes.
qualitative.
Yes.
Anything we missed, Dr. Shanti? Can we go ahead with the second case? Okay, go ahead with the second case.
Vinodini.
In India, what is the percentage of our
5%, ma'am.
Okay. 5%. Okay.
What is the difference between ICT and DCT that we have missed?
Yeah.
Ma'am, ICT is indirect Coombs test, ma'am, where we take the maternal serum, mix it with.
What are we looking in ICT and what we are looking in DCT? Can you explain to me? ICT is done with maternal blood.
Yes,
And what we are looking at is?
if the maternal blood has antibodies, ma'am.
Okay. So what
And,
we have to add extra in ICT?
The serum, ma'am, rabbit serum.
RBCs. Okay.
And in DCT, we check for the baby's blood, ma'am, to see if the antibodies are still coated to the fetal RBCs.
There is no need for the adding
Anti-serum.
Sera, though you have to add. AHA, you have anti. You have to add, but you don't have to add RBCs in that, rapid RBCs.
Yes.
Where to give anti-D? Which part of the body to give anti-D?
Deltoid, ma'am.
Why not gluteal region?
Because the absorption is lower, ma'am, because of the subcutaneous fat.
Okay. And with what are different types of anti-D?
What is the route, ma? Only intramuscular is available?
Intravenous also, ma'am.
No, we usually don't give. What are the conditions in which you will give intravenous? We usually don't give it intravenous.
We have certain conditions in oncology, all that, other things. So where do you give, ma?
Where IM is contraindicated, ma'am. Thrombocytopenia.
Thrombocytopenia, then only. Otherwise, it can lead to anaphylaxis. What are different types of anti-D? You can see polyclonal, monoclonal. What do you understand by that?
And polyclonal, we get the serum from multiple donors, ma'am.
Okay.
And we screen them for viruses and then we produce the
So which is better? Polyclonal is better or monoclonal is better?
polyclonal.
Polyclonal is old one, ma. So then which is better?
Monoclonal.
Now what do we use more? See, this also you need more than monoclonal. What do we use now? Everything is recombinant nowadays. Okay?
Yes.
So you have to talk about that. It's available, Amma.
Yes, ma'am.
Okay.
So advantage of polyclonal is that it covers all the epitopes. So both are available, and polyclonal is the older one, and the monoclonal, most of them recently available are monoclonal.
Yes, ma'am.
How will you manage intrapartum management of a woman who has RH negative? She is not sensitized. She is not aluminized. How will you manage intrapartum management? That we have not discussed.
We plan the delivery around 40 weeks, ma'am.
What all precautions you will take to prevent the sensitization? What all precautions you will take?
Ma'am, in normal delivery, we don't give ergometrin, ma'am. We avoid manual removal of placenta. In cesarean section, we minimize the spill of blood into the peritoneal cavity.
Anything
should
else?
be
We do an early cord clamping for the baby, ma'am.
Do we
Now-
do now is early cord clamping preferred nowadays?
There is a lot of evidence now that there is
is
no
not-
need to do, huh?
Yeah,
Do delayed cord clamping.
that is
Why
very,
do you-
very important. We cover the postpartum with anti-D, isn't it? So
Yes, ma'am.
the benefits of delayed cord clamping for the baby outweighs all these risks. Okay, so it's
Yes.
very important. Okay, earlier only we used to have long cord so that we can actually. Now all advances have come, so that is not needed now. When we were youngsters, it used to be there. Okay. Okay. What about the second case, Amma? Second case, Vinodini or something they said, somebody.
Yeah. This presentation. Okay. Ma'am, just one.
Ma'am, it's mute.
She is coming, madam. 2 minutes. She's in the hospital. There is a power cut. Her presentation is there on laptop. So I told her to try to do in the mobile.
Mobile will be difficult.
Yeah, otherwise you see, like you can do.
I think we can continue the discussion, Dr. Shanti. Anything else you want to clarify for the postgraduates?
Ma, at least you present, even if you from your this thing you can present, Amma. Your laptop is not charged.
No, got in the hospital. So she is there in the hospital.
Thank
So
you,
that is
Bobby.
why she was not able to, like, I told her she's coming out of the room and she's doing somewhere there.
At least let her read her presentation.
Okay, ma'am. I'll tell you.
Suppose we said this patient RH isoionization had occurred. And then, of course, we have to follow up with all these things. But suppose if the what is that titer keeps on increasing, MCA PSV is more than 1.5 mom. That event, what will you be doing, Amma?
Ma'am, we do an amniocentesis.
Why do you want to do amniocentesis when it is more than 1.5? We are no longer doing amniocentesis.
We plan for delivery if gestational age is more than 34, ma'am. If it's less than 34, then we give intrauterine
34 or 35, ma? One is the
35.
Amma?
Ma'am.
35, ma. Okay. If it is less than 35, you call it as remote some term for RH incompatibility. Okay. So, and this, okay, please continue, Shanas.
Ma'am, we give intrauterine transfusion, ma'am.
So which type of blood you give for intrauterine transfusion, Shaheen?
O negative, ma'am. And ABO compatible with the, sorry, ma'am. O negative and leukocyte depleted blood, ma'am. Fresh blood of less than 5 days.
Yes. Anything
and,
else?
And SEMB tested and should be negative, ma'am.
Or anything else should be irradiated.
Irradiated, ma'am.
Okay. After that, what do you do, ma? Okay, you're given one IUT now. Okay. After that, what do you do?
How do you calculate the amount you will give for blood? What should be the hematocrit of the blood you will transfuse?
About 70 to 80%, ma'am.
Why? What are the indications for giving IUT? How much should be the fetal hematocrit?
Less than 30%, ma'am.
So you usually give when it is less than 30% or 2 standard deviation, what is expected for that POG. So how do you calculate the amount of blood to be given? You have told us O negative.
Ma'am, there's a formula where we subtract the target hematocrit, the target hematocrit minus the fetus hematocrit by the donor's hematocrit into the multiplied by the fetal placental volume.
No, it's a very complicated formula here. There's a very simple formula which we are using in a hospital, is followed by AIMS also. This is known as RODAC formula.
Yeah.
You just have to do ultrasound. We have to calculate the estimated fetal weight, and we have to multiply it with a coefficient 0.02. That increases the hematocrit by 10%.
Okay.
So increases by 10% if you give a transfused blood has a hematocrit of 75%. So this is very easy to, and usually we have 60 to 80 ml of blood we give at one transfusion. So
Yes.
before you start the transfusion, and you have to take out the blood to check the hematocrit. Okay. So that's how you do it. You do the calculation. And how much is the target hematocrit when you're doing IUT? How much target hematocrit you want
50%.
after so around 45 to 55%. And hydrops occur when? What is the hematocrit at which level the
Less than
hydrops
25.
less than hematocrit less than
25, ma'am.
15%. Usually hydrops occur when the hematocrit is less than 15%. And
Yeah.
what are the features of hydrops? Can you tell what do you mean by immune hydrops? This Rh negative causes immune. And there is another entity known as non-immune. Okay. So how does a baby of immune hydrops will present?
What are the characteristics, ma?
Yes, ma'am. The ultrasound characteristics of fetal hydrops are skin edema, scalp edema.
How much is the scalp edema? Should be more than 5 mm. Okay.
Yes,
And there should be
third space collection, pleural effusion, ascites, pericardial effusion.
Okay, how many factors should be there to say it is hydrops fetalis? 2 or more. That is
Okay,
what we
2.
generally say. Okay.
Yes,
So
ma'am.
to say hydrops, the baby should have pleural effusion plus ascites, pleural effusion plus pericardial effusion. Okay, so 2 features should be there to label baby as hydrops. What about placentromegaly? That is
More
also
than 4. Yes, ma'am. More than 4 centimeters.
So 4 to 6. Usually for second trimester we take it cut off as 4 centimeter, and for third we take it as 6 centimeter.
Yes.
What happens to platelets, Amma? Platelets, then white blood cells. What happens? You told about hemoglobin. Okay. So we say hemoglobin less than 5 gram per deciliter or a hematocrit less than 15%. What about platelets generally? What happens to platelets? They will have thrombocytopenia. Okay.
Yes.
So that we should always remember. Okay, ma. What happened? The other person has
Yes,
not.
ma'am.
Then are you ready?
Yes, ma'am.
Yeah.
So what is mirror effect? If baby has hydrops, what is mirror effect on the
Ma'am,
mother?
the Rh negative mother who has an Rh positive baby has fetal edema, proteinuria,
So
and
this mirror effect occurs with all hydrops. Okay. The baby is also swollen and the mother also gets swollen with all PE, and so that is known as mirror effect.
What is grandmother theory, ma? People keep on talking about that, no?
ma'am, the present Rh negative mother, when she was a fetus in an Rh positive mother, the Rh positive bloods from, the RBCs from her system enters into the Rh negative fetus, and it causes a primary sensitization. And when that fetus becomes positive with another Rh positive fetus, the secondary sensitization occurs, and this is one of the theories for alloimmunization in primary gravida.
Achha, Shaheen, why first baby is not affected? Only the second baby is affected. Why?
Because the primary antibody is IgM, which doesn't cause
When does feto-maternal hemorrhage? You only told feto-maternal hemorrhage occurs as pregnancy advances, isn't it?
Yes, ma'am.
Then what happens? Initially,
so initially IgM is produced, ma'am, and it is a larger molecule and doesn't cross the placenta. So later, when she becomes pregnant with another Rh positive baby, IgG antibodies are.
When sensitization occurs, Then shortly soon after, IgG antibodies start rising. But by the time she would have delivered generally. Okay.
Yes,
So
ma'am.
that is the thing which you have to tell. So in the next pregnancy, there are already IgG antibodies which are available. Okay.
So you're starting the case?
Yes, ma'am.
What's your good name?
This is Dr. Vinodini, ma'am, primary DNB candidate.
Okay, Vinodni, start.
Mrs. Z, a 26-year-old homemaker by occupation. She is a booked the case at Apollo Women's Hospital, belonging to upper middle socio-economic class according to modified Kuppasamy classification, and she's residing in Nungambakam. Her blood group is O negative and her husband's blood group is B positive. She is a primary gravida with 38 weeks of gestation, has come for routine antenatal checkup. She perceives fetal movements well, with no complaints of bleeding or leaking per vaginum or pain abdomen. Her LMP is 1/5/2022 and EDD 8/2/2023.
Please
One
continue.
second, ma'am. History of present pregnancy. First trimester, she has conceived through ovulation induction. Confirmed by she confirmed a pregnancy by urine pregnancy test at 45 days of amenorrhea. Folic acid has been taken regularly. Blood grouping and typing has been done in the first visit, which shows O negative, and her husband's blood group is positive. Indirect Coombs is done, which is negative in the first trimester. Dating scan done and dates were corresponding. NT scan was told normal. And first trimester
Do you do
screening.
antibody screening routinely?
No, ma'am.
Why? I've seen in so many.
Many places they are doing routinely for.
What is the recommendation? Okay, ma, please continue.
Okay, ma'am. And NT scan done, which is normal. No history of excessive vomiting, bleeding per vaginum, abdominal pain, fever with rash, UTI or radiation exposure. Second trimester, quickening felt at 5th month. Injection TT 1 dose are taken at 28th week. And for our repeat ICT done at 28 weeks, which is found to be
Why
negative.
TT was given, ma?
It is TT or TDAP, Vinodini?
Ma'am,
We don't give TT at 28 weeks, no?
yes, ma'am. TDAP, ma'am.
TT
And
is
why-
never given in pregnancy. We are not supposed to
TD.
give it. Yeah, we are supposed to give at least TT.
TD.
That
Yes.
is the WHO recommendation. That is the Ministry of Health Family Welfare recommendation. Since many years.
Okay, ma'am.
Either you can give TD or you can give TDAP. You are not giving TT nowadays.
Yes, ma'am.
In our tertiary hospital, we have TD available. It's available.
Yeah.
Government is providing nowadays TD. No?
Yes.
Okay.
Okay. And repeat ICD done at 28 weeks, we found to be negative, and anti-D prophylaxis of 300 microgram IM stat given. Iron and calcium supplements are taken regularly. Anomaly scan done and anomaly is ruled out. OGTT
What
done
anomaly scan done, ma?
24 weeks, ma'am.
Why at 24 weeks you do
Normally
anomaly?
scan 24 weeks.
What is the
20.
legal limit of termination in India now? What is the legal limit? Till legally for gross congenital anomaly, you can terminate pregnancy up to 24 weeks.
24.
Huh?
24. It is a recent one.
So you at least you get it done around
24.
22 weeks so that you have enough time. to
See,
get abortion.
anomaly scan we do 18 to 22 weeks. No, we don't do it.
Now we have increased it to 20 to 22 in case the patient is sensible one.
Yes.
So that some delayed present day anomalies are detected. Okay. So at
Okay,
18
ma'am.
to 22, you should get it done. 24 is too late.
Yes, ma'am. 22, ma'am. Sorry.
And GTT is wrong word.
Come in order, Vinodini.
Yes,
See,
ma'am.
anomaly scan will come early. Then
Okay, ma'am.
if is given also will come early. Okay.
Okay,
So
ma'am.
you have to come in an order, Amma.
Yes, ma'am.
Okay.
No history of elevated blood pressure, no history of urinary tract infection or increased white discharge per vaginum, no history of bleeding, leaking, PV or pain abdomen, no history of any invasive procedures.
It should be OGTT, not GTT. It's
Yes,
wrong.
ma'am. Yes,
Oral
ma'am. Oral
glucose
glucose tolerance. Yes. And third trimester, she continues to perceive the fetal movements well. Iron and calcium supplements were continued. Growth scan done and growth of fetus satisfactory. No history of bleeding PV or pain abdomen.
Growth
And
scan, ma, generally.
ma'am,
When do you do growth scan, amma?
28 to 32 weeks, ma'am.
Yeah, generally. From 32, we have now shifted to 28, generally, isn't it?
Yes, ma'am.
Okay. Hmm.
And present pregnancy is uneven full. Marital history, she is married for 7 years, non-consanguineous marriage, and husband's blood group is B positive. No history of any contraceptive methods used. Menstrual history, irregular cycles, 5 days flow, and her LMP is 1522. Past medical history, she's a known case of bronchial asthma since childhood, not on any regular medications, on inhalers, SOS. Not a known case of diabetic hypertension, tuberculosis, epilepsy. She's known case of PCOS. Surgical history, she had an hysteroscopic polypectomy in the year 2021, and a histopathological examination shows benign endometrial polyp. No history of any blood transfusion or no history of abdominal trauma.
There is one case of PCOS. So when all you will repeat her OGTT. You have done it now at first. How many times you have done for this case?
For her, in the first,
Please tell, ma.
for her in the first visit, ma'am.
Ah?
Then
Then
then-
Ma, any patient, how are you supposed to do?
OGTT is usually done between 20 to 24 weeks, ma'am.
First time? Ma,
First,
visit you have to do, ma.
yes,
not
ma'am.
20,
TDM
24,
screening we don't do
22
at
to
24 to 28. You see, do at the first visit, no, Vinodini?
Yes, ma'am. First visit plus after that.
After that, if it is negative, again you have to repeat it.
24 to 28 because that's the peak when there is insulin resistance. Okay.
Yeah,
Yes.
this
In
is
this
MOH
case,
family welfare recommendation. What is Tamil Nadu government recommendation?
No, ma'am.
First visit 24 to 28, 32 again. That is not there in MOH family welfare, this thing, but we are supposed to do it. And especially for this PCOS, it's
Patient.
very,
do
very.
it at 32. Even I will do
2 weeks like OGCT or OGTT coming positive.
so we should report.
Yeah, we should repeat it.
Okay, ma'am.
Okay, ma, please see what is the significance of surgical history you are telling.
Yes.
Surgical history means that was earlier your meaning. What is the history of abdominal trauma?
No, ma'am.
When
No.
is abdominal trauma relevant for this patient? Amma Vinodini,
Yes, ma'am. Yes.
when is see you have written no history of abdominal trauma.
Yes,
Okay.
ma'am.
When is
What,
abdominal trauma relevant for this patient?
In case of abdominal trauma, she might there might be some kind of hemorrhage, no, ma'am.
Hmm.
this is your surgical history, it's not the current
Yes.
pregnancy history. So they
Yeah,
would
yeah,
not irrelevant.
It is not relevant. See, ma, generally, if she is pregnant and she has an abdominal trauma, blood trauma, like that, then she can have. Okay. But
Yes.
otherwise, generally, okay. Then what else?
Family history, no history of any comorbidities in family members, and mixed diet, good appetite, normal bowel and bladder habits. General examination is nothing significant, ma'am. After getting informed consent,
You
the
told about
examination-
abdominal trauma. You didn't tell me about blood transfusion, which is more relevant.
I've mentioned, ma'am, but it was in the wrong place, ma'am.
It should be in the right place.
Yes, ma'am. Sorry, ma'am.
Okay, ma. Okay.
And a present weight 68 kgs. So total weight gain in her entire pregnancy is around 8 kgs, and her BMI is 24.6 kg. Vitals, she's stable, ma'am. Everything is normal.
Okay. Tell the
No
positive.
failure.
Tell the positive finding. Yeah, there is nothing positive. Huh? Go
Yes.
ahead.
And her abdomen is longitudinally distended on inspection. Abdomen longitudinally distended, flanks full, umbilicus in the midline, flushed with the surface. Linea nigra seen, stria gravidarum is seen. No dilated veins or scars. Hernial orifice is free. On palpation, she is examined in supine position with legs semi-flexed. Fundal height corresponds to 38 weeks of gestation, and symphysia fundal height around 37 centimeter, ma'am.
Is it, you have written 32?
Yes, ma'am, that's wrong. 37, ma'am.
I think you should go through your presentation before presenting, ma.
Yes, ma'am.
Same thing holds good in exams too. Sometimes the examiner will take your paper and see the contradictions. Okay.
Yes. Okay, ma'am. Fundal grip is soft, broad, non-independently ballotable pole, fell suggestive of breech, and lateral grip, left side uniform curved resistance fell suggestive of back, and right side irregular fetal parts felt. First pelvic grip, hard, round, independently ballotable pole, fell suggestive of head, and 4/5 is palpable. Second pelvic grip, findings of first pelvic grip confirmed, clinically like adequate. Auscultation, fetal heart zone heard in
Why
the left
will you
spinal
write
umbilical.
clinical? Like that should come in the lateral grip. Why will you write in pelvic grip clinically like adequate? Here you are not assessing whether you are seeing whether the part is engaged or not.
Yes,
That has
ma'am.
come in the wrong place. That's what we
in the
know.
wrong place.
No, ma'am, no.
You
No,
should
ma'am.
write in the palpation, amma.
Yes,
Or
ma'am.
after everything, okay. Please tell.
Auscultation, fetal heart zone heard in the left spinal umbilical line, 148 beats per minute, regular and rate and rhythm.
Yeah,
So
please.
summary, 28-year-old Mrs. Z, primary gravida, 38 weeks of gestation, booked and immunized, a case of RH negative pregnancy, non-allo immunized with a single live fetus and cephalic presentation, has come for routine antenatal checkup. Provisional diagnosis, primary gravida, 30 weeks of gestation, RH negative, a single live fetus, longitudinal lie, cephalic with presentation with good fetal heart rate.
Have you given NTD to this patient? I think you have said 28 weeks you had given NTD.
Yes, ma'am.
How much did you give, ma?
300 microgram, ma'am.
Okay. Do you know about 2 doses being given? 2 doses of anti-D be given? Not in India, some give, but then generally in certain countries that is being given. What is the dose there?
Is it?
It's not in India, but you should know. All of you all write other exams too, isn't it?
It is given 300 microgram or less.
If you
Less
give
than how much?
150, ma'am.
Not 150, ma. 100, ma.
100.
At what period?
One at 28 weeks and the other one at 32 weeks, ma'am.
32
Yeah,
to
other at
34.
32 weeks.
32 to
Okay.
34.
So suppose this patient says, why do you want me to take anti-D? What will you tell her?
To prevent allo immunization, ma'am.
When does allo immunization occur?
When there is a fetal-maternal hemorrhage, when there is exchange of the maternal and fetal circulation.
What is the chances of she being exposed antenatally? Because you're giving her antenatally without knowing the blood group of the baby. Maybe baby is negative.
See, if the baby is negative,
Yes, ma'am.
is there a need for anti-D?
No, ma'am.
When can the baby be negative?
When the father is heterozygous or RH negative.
How will you identify? So if you know that the baby,
Cell-free,
there are certain methods to tell us probably the baby is negative. How will you identify that the baby is negative?
cell-free fetal DNA testing can be done, ma'am. Antenatally
See,
from the
cell-free
maternal plasma.
is freely available in India, but not for RH negative, at least in Chennai, so far as I know. Maybe now for a few months.
In Delhi also, Delhi also we are getting NIPD done. It's just no, we are not. We can't.
Cell-free DNA is available, but for finding out the typing, it is not available in Chennai. That much we know. But in Canada, so many countries, they just do that. And then, so what is the, suppose they have done a cell-free DNA. So just tell me, how will you proceed further? Vinodini?
Yes, ma'am.
Yeah. See cell-free DNA if it is available. For whom do you see cell-free DNA?
From the maternal plasma, ma'am.
Or from the mother? Good. What does it represent?
The not sure.
What is cell-free fetal DNA? That is what the whole expansion is of. So it tells us about the fetal cells. Okay.
Yes, ma'am.
So suppose if you think this facility is available in Chennai. So what will be the, how will you interpret it? That's what I'm asking.
We
If
can
she
detect
is
the
positive, what
fetal
is she will do?
blood group, ma'am.
Pardon?
To detect the fetal blood group.
I know.
In which
what will you
condition
do?
you want to know the
If
fetal
she's
blood?
positive, what will you do? If the baby is positive, what will you do? If the baby is negative, what will you do?
If the baby is negative, we don't have to do anything, ma'am. Only the routine care has to be
But
continued.
can you be 100% sure? If the patients will ask all these doubts, isn't it?
Yes, ma'am.
Is it a screening test or it is a diagnostic test?
It has 99% sensitivity and specificity, ma'am.
Specific. Okay. So suppose, this is, if you are not testing the baby, how else can you decide whether to give anti-D or not?
Based on the father's.
Justify your giving antenatally, anti-D.
Mm.
If father is homozygous, what is the chance of baby being positive? And when it's heterozygous, what is the chance? Can you tell us?
Ma'am, heterozygous, there is 50%, ma'am. 50% of baby being negative and 50% of being positive. Whereas homozygous, the fetus will be at risk of RH positive only.
100%.
100%.
100%.
If we don't know, it's around 60%.
62.5%. Okay. So how do you actually identify that whether husband is homozygous or heterozygous? We
A
don't.
genotyping of the husband has to be done, ma'am.
Okay. Okay, ma. Okay, this patient, what are you going to do?
Now she's 38 weeks. How are you going to monitor her? Manage.
Yeah, you will monitor her. You will explain about the labor to her, and we just go for the spontaneous progression of labor, ma'am.
If she becomes 40 weeks, then what will you do? She is at present 38. Then will you allow her to go post-dated beyond 40 weeks?
No, ma'am.
Why?
The percentage of the fetal-maternal hemorrhage will be excess after the time.
Vinodini,
that
already
is not the
answered
reason.
The half-life,
That is not the reason.
the anti-D is only valid up to 12 weeks, ma'am. We give one at 28.
So because the effect of anti-D will go off in 12 weeks. So you want to deliver her around about 40 weeks. And once baby, then if she delivers vaginally, then what will you do? How will you manage it further, the case?
Ma'am, prophylactically, ergometrin should not be given, ma'am. And you do
we can't hear you.
Vinodini?
I think this part we have already discussed how we'll manage the what all.
Yeah, what happens to the baby, ma? Suppose, suppose she is allo-immunized. Okay, we have followed her up. We have what type of delivery will you give, ma? If you want to deliver her, what is what route will you deliver?
I think she's not.
I think one of the PGs can take over. Shanas, you're there, no? What happened to Vinodini? Shanas?
Senaj, you can answer. What is the mode of delivery if it is allo-immunized?
Ma'am, vaginal delivery.
See, you should have, we say cesarean, vaginal delivery can be given, but have given so much IUT, all that, no, you'll be really scared.
High risk pregnancy.
Of course, so that you have to have it always in your mind. Vaginal delivery is not a contraindication, but then if you had given up, given
Unfavorable.
IUTs, intrauterine transfusion, all that, you'll be really scared to subject the baby. So you have to think about all those things. Okay. So suppose her, you are delivering her because she's allo immunized and she's 37 weeks. Okay. Then what do you do? What do you do, Ma? What happens to the baby? What should be done to the baby?
Electronic fetal monitoring has to be done, ma'am, during labor.
We have delivered, handed over
Oh,
to
valid.
After
Ma'am,
delivery.
we look for the bilirubin levels and the hemoglobin levels, ma'am.
There is no need for blood group if you have given IUT. Oh.
Yes, ma'am.
So that those babies who are born to mothers who have already received IUT, what are the risks to those babies?
They can have delayed anemia, ma'am.
So the antibodies can persist for almost 12 weeks. So they may need extrauterine transfusion also.
Yes, ma'am.
So they have to be under continuous pediatric care for need for extrauterine transfusions.
Phototherapy.
Okay. Suppose allo immunization is there, Ma. What is the role of see patient has ICT positive? Okay. So in that even what is the role of anti-D?
We don't give, ma'am.
No role at all. So how do you prevent hemolytic disease of fetus and newborn in an allo immunized woman? She's
Ma'am,
already, she has had many pregnancies.
There is no use of ICT, ma'am. So we start doing the MCA Doppler from 16 weeks of gestation.
Yeah. But if she has had a fetal demise, this hydrops quite early, okay, she might be, you might have to start following up quite early, okay. You can do Doppler only from which period of gestation?
16.
No, MCA PSV you can start doing only from 18 to 20 weeks. You can't do before that. And if there is history that patient has hydrops earlier to that, what are the other options we have besides IUT?
What are the other options? That's
not possible to do IUT before 18 to 20 weeks. So what other options? If she has hydrops at an earlier period of gestation, then?
She also would like to have a baby, no? So what are the options?
Plasmapheresis.
No, plasmapheresis is for the mother. Okay, see, you can either insemination with sperm from an Rh negative donor. Okay, only if the husband is baby is positive, all problems will be more. Okay, and you can also talk about IVF and pre-implantation genetic testing for selection of Rh negative embryos and gestational carrier. So all these options now, of course, with our bill, probably I really do not know. But then all these points you should remember. What are the other options for you? Okay.
What is the role of IVIG, Shaheen?
Ma'am,
IVIG?
It reduces the duration to prolong the intrauterine transfusion, ma'am. It's currently under study, but we can give, studies are showing that we can give a dose between 5 and 15 grams, ma'am.
So IVIG has a role when if it's occurring very early. Okay, so you can, it's not feasible to do IUT before 18 weeks. So if it's occurring before that, you can increase it, prolong it to prevent fetal anemia till 18 to 20 weeks by giving IVIG. And what is the normal hematocrit fall after IUT?
Fall 1%
per day, ma'am.
1%. So, but if you give IVIG along with IUT, you can reduce it by half almost. The fall in hematocrit. Okay, so it will increase the amount of days in between 2 IUTs. So is there any role of MCA-PSV after you have done 2 IUTs? Usually, if you're given twice intrauterine transfusion, is there any role of MCA-PSV? Any idea? So after 2 IUTs, it's not very reliable. You get a very high false positive. Okay, then you have to basically repeat the transfusion based on the hematocrit which was there at the last transfusion.
Yes, ma'am.
MCA-PSV can't be used for diagnosing fetal anemia after you have given you have done 2 intrauterine transfusion. Anything else, Dr. Shanti?
After 36 weeks, it's not so reliable, the MCA-PSV.
MCA-PSV is reliable from 18 to 35 weeks only, because after that the cardiac output increases and you don't get the values of MCA-PSV is not very reliable. That's why we usually deliver them after 35 weeks if the MCA-PSV is more.
Yes.
In we are routinely doing MCA-PSV, but in case the patient has not received IUT, then we can keep on doing that only, but its reliability decreases after 35 weeks of MCA-PSV.
Dr. Saxena, good evening. I'm Dr. Uma here from Hyderabad.
Good evening, madam.
Good evening, ma'am. Can you explain us regarding the DU variant? We had a case of DU variant.
DU variant, you have to take, it's V positive, but you have to take it as positive only. You have to treat them as RH positive. DU variant.
Always in cord blood, generally, we see for that thing also before giving anti-D. So it is serologic weak D phenotype. Earlier we used to call DU positive.
Yeah. Any query when you are reading?
Any questions, ma'am?
Any queries? What was the principle of amniocentesis when we were doing earlier? It's now obsolete. It's the invasive technique. What was the principle? Anyone, Shaheen, can you tell me?
Yes, ma'am. Ma'am, the amniotic fluid, which is mixed with bilirubin, has a deviation from the linearity at optical density of 450 nanometers, ma'am. So we do it between 350 and 700 nanometers, and we look for the variation from the linearity at 450 nanometers, ma'am. And we plot it in the graph.
So what is the, I'm just reiterating, what is the advantage of MCA-PSV over amniocentesis? There are many advantages. What are the advantages?
Non-invasive, ma'am.
Besides that, you get a false result because of blood and meconium, which is not there with MCA-PSV. It is easy to insinuate and easy to follow up. And every time you do amniocentesis in a sensitized mother, you are increasing the exposing her more.
Yes.
So which is, it's a totally non-invasive test. And what are the complications of cordocentesis? And where you do IUT? Where all places you can do IUT, intrauterine transfusion. And what are its complications? We did not discuss that.
We do the IUT in the umbilical vein, ma'am.
Where?
Using at the point of entry into the placenta, ma'am.
Why we do there? Why we do there? Because it's a fixed point. And we usually paralyze the baby.
Fetus, yes.
Fetus before we do it. And any other place besides placental insertion. And how do you identify umbilical vein? Any idea? How many blood vessels are there in the cord?
2 arteries and 1 vein.
So vein is, and we usually identify by putting the Doppler. Okay, so it's you see continuous smooth pattern as you see in a venous flow. And where else besides umbilical vein in cord and placenta and intrahepatic portion?
Intraperitoneal, intracardiac can be given, ma'am.
usually that is avoided. You can give it in the intrahepatic part of the umbilical vein. Okay, that is the other place you can give. And what is the indication of intraperitoneal transfusion? When you should give intraperitoneal?
Early,
Yeah.
when we need transfusion early in the pregnancy, ma'am. When
So
umbilical vein
before
is
18 weeks, before you are able to do chordocentesis, then you can give intraperitoneal, but it is not so successful because it takes much more time for blood to be absorbed from the peritoneal cavity. And what is the complication of chordocentesis?
ma'am, there's a risk of fetal maternal hemorrhage. There is
Cord
a risk of
hematoma.
fetal hematoma. I mean, cord hematoma.
Cord hematoma, yes.
Fetal distress, ma'am.
Yeah, so you have to, in a case of a viable fetus, you have to monitor for 1 hour, and you should do IUT in a place which is near to OT. So that in case there is bradycardia, you can take up the patient for C-section, and you can give steroid also. And during IUT, you have to give antibiotics. That is also a must. Any other complication? Preterm premature rupture of membrane is also more common with when you do IUTs and you do
Chorioamnionitis.
and chorioamnionitis. Yeah, these are all the complications.
Is the D antigen detectable in RBCs, ma'am?
Surface, ma'am.
Pardon?
Oh, when, ma'am? When 34 days, ma'am, gestation.
38 days after conception. But still, sensitization is very less. So only we do not give routine anti-D when we have problem quite early. Okay.
So which are the conditions where the sensitization is maximum antenatally? Which are those conditions? We have discussed MTP, ectopic pregnancy, molar pregnancy, anything else?
Abrupt antepartum hemorrhage, ma'am.
Okay.
ECD.
So don't forget, I just reiterating, don't forget to get this ABORH done for all ectopic women. We are operating for ectopic. Nowadays, the incidence of ectopic is increasing. Every day we in our hospital, we're doing 3-4 laparotomies for ectopic. So always get a ABORH done and give anti-D.
Yes.
What are the invasive prenatal diagnostic or therapeutic procedures where you will give anti-D, ma'am?
Chorionic villus sampling and amniocentesis, ma'am.
Chordocentesis.
Amnio infusion, fetal blood sampling, fetoscopic surgery, okay, multifetal reduction, all that.
Yes, ma'am.
ECV also we have to remember, ma'am.
Yes, ma'am.
ECV we have to give anti-D. Fetal death we have to give anti-D. Okay. Okay. Any doubts, ma'am? Any doubts?
Ma'am, for ECV, fetal death, all the dose, ma'am, is it low dose or?
No, we do not either. We give it routinely, we give only 300. We do not give less.
Okay, ma'am.
What happens if you give anti-D immunoglobulin to a D positive individual? RH negative, you give. What happens if she is RH positive? What happens, Sama? So the thing is, it is not harmful, but then a positive DCT can occur for some time for the woman. So that we should know. So many times in hospital, for one patient, they give for the other patient, all that, no? So we should know this. Okay. Okay. Anything else, ma? Any doubts, ma?
What is the success rate for IUT in hydrops and non-hydrops fetus? If you do it for hydrop or non-hydropic, any idea? Anyone, Shaheen?
94%, ma'am.
So for a non-hydropic,
hydropic and 84 in non-hydropic, ma'am.
So around 94% success rate for a non-hydropic and around 70 to 80% for hydroponic. So you usually want to give before the baby. And if you don't do IUTs and she's sensitized, what is the percentage that the baby will become hydropic? If you are not giving IUTs to a alloimmunized mother, then what is the chance of baby being hydropic? Around 1/4 of the women will have a hydrop. Okay, 25%.
Okay.
All these patients, we have to start antenatal testing at 32 weeks for a child's immunization. Even if critical titer is not raised, that madam already said, but you should remember that you have to specifically tell that. Okay, anything else?
I think we have covered everything. My questions are also finished.
Okay.
So if any query, otherwise we can finish now the session. Any query from anyone when they were reading? Any student, they can ask. It's a complex topic. It's not straightforward.
So previously, when we were all students, we used to talk about Liley's curve, all that got. You never answered my question, Ma. Why bilirubin? You told me you were seeing bilirubin. Why did you see bilirubin?
See, for neonatal hyperbilirubinemia, ma'am.
No, but why?
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 To give phototherapy, to prevent Kernick stress, ma'am. Kernick stress.
Hemolysis. Alloimmunization that results in hemolysis of the RBCs, fetal RBCs. So what is the byproduct of
Yes.
that? It is bilirubin. So it is essentially hemolytic. Okay. So that is the basis for seeing bilirubin. Okay.
Baby, you should understand, baby's serum bill never rises when intrauterine. So it becomes high only when the baby is born. Okay. So intrauterine life, the baby is not affected. Only the amniotic fluid bilirubin is high, which we are seeing through
That is important. That is also very important.
And what is connecteris? Anyone? What do you understand by connecteris?
Yellow stain of
Gets
the
deposited in the basal ganglia.
When does it occur?
bilirubin levels are more than 20 mg per deciliter, ma'am.
Okay. So in that event, what will you do? It is rising, then what will you do?
Exchange transfusion, ma'am.
What is the indication for exchange transfusion?
Hemoglobin less than 11 grams, ma'am. Cord bilirubin more than 4.5 mg per deciliter.
And the rise.
And rise more than 1 mg per kg.
So how does the exchange transfusion helps? Last question. How does it helps?
Ma'am, it removes the coated RBCs, ma'am.
So it removes the coated, it reduces the antibody level. And anything else? It corrects the anemia because baby is anemic. Anything else? It reduces the bilirubin level in the baby.
Levels.
So in these way, the exchange transfusion helps the baby. It prevents connectors.
Yes, ma'am.
Any doubts? It was really nice having Dr. Saxena, Sunita, and Sumanna.
Thank you, ma'am. It was a very nice discussion, Sakshana ma'am.
I don't have anything to say, Shanti.
Yeah.
We're just listening. Very nice, Uma. Thank you very much.
Thank you, man.
Thank you.
Okay, then we can leave.
Thank you. Yeah, bye.
Thank you, ma'am.
Thanks for inviting.
Thank you, ma'am.
Thank you.
Thank you, ma'am.